This podcast is brought to you by Podcast Nation.
Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome back to the As a Woman podcast. I'm so honored to have you guys here. Thank you for all your support. I want to dive into mini Stim IVF today, or minimal stimulation IVF. For the most part, the too long don't listen. This is a marketing ploy that a lot of clinics use. That's not to say that there isn't a role and a place for a minimal stim protocol. I have one in my book of protocols, or the things I like to use. But today I'm going to talk you through the scenarios where it's appropriate and the scenarios where it's not, and how sometimes clinics may market this and make it seem so appealing, and you're actually doing yourself a disservice, having a lower chance of success, and spending more money, which ultimately is not what we want, right? If you need or choose to do IVF for whatever reason, I know that you want to get pregnant as fast as possible, and you want it to be with as few of side effects and spend the least amount of money, but ultimately, you're looking for that result. All right, but before we dive in, just want to say a huge thank you for being here. Your support of this podcast has kept it going strong. I have taken Fertility in the News, which is one of my favorite segments, and it is in the newsletter. So if you are not aware, please sign up for the newsletter, nataliecrawfordmd.com/newsletter. You will find some of my favorite things, recipes, updates, but you'll also find every newsletter answers to fertility questions and my take on some of the latest topics of the fertility news, which it's a wild world out there, y'all. It is fascinating. So again, that's nataliecrawfordmd.com/newsletter, and you can sign up. So in order to understand mini stim IVF, you have to understand IVF, you have to understand how the ovary works. So quickly, I'm going to walk you through that. Then I'm going to talk to you about the shortest version of IVF possible, IVF in 2 minutes. And then I'm going to talk to you about what it really means to say mini stim. When we think of the ovary, I want you to imagine that inside the ovary is a vault where all your eggs are kept. Now, when you're born, the vault is full. As we have discussed many times, throughout the course of your life, you lose eggs from the vault every single month. And then when the vault is empty, you're in menopause. So this vault is representing your reproductive lifespan. What is actually happening is every month you have a group of eggs come out of the vault. Each egg is microscopic, and each egg grows inside a follicle, which is a small fluid-filled structure. Follicles you can see on ultrasound. Eggs are microscopic. Well, a group of follicles is available every month, and then the brain sends out follicle-stimulating hormone, or FSH. FSH is what's called a gonadotropin, comes from the pituitary gland, and it stimulates the gonad, in the female body, that's the ovary, to make estrogen as it's making an egg. So FSH is well named. FSH stimulates a follicle to grow. As the follicle grows, it makes estrogen and the egg matures. When that estrogen level is high enough to indicate a mature egg, the body then sends out an LH surge. You ovulate. That follicle becomes a corpus luteum. Rest of the eggs or follicles that were available die. Next month, another group comes out. And this process is happening over and over and over. So if you got pregnant in that cycle, the next month, another group of eggs still becomes available. But there is no FSH because you're pregnant. So therefore, that whole group of eggs just dies. Same thing when you're on birth control pills. A group of eggs becomes available. There's no FSH because you're on birth control pills. The estrogen in the birth control pill, or the estrogen in the pregnancy, tells the brain, we don't need an egg right now, we've got estrogen. Therefore, the brain does not send out FSH. So that group of eggs just dies. This process starts when we are inside our mother's womb. We are losing eggs every single month. You don't start giving one a chance to become a baby until puberty. Puberty is the brain turning on. Now, the very interesting thing is that when the vault is more full, more eggs are available every month. And as the vault is less full, fewer eggs are available every month. And this is a very important concept for IVF. I like to think about the vault as self-regulating. You guys, there's no actual vault. This is an analogy. Really, these eggs are just so dormant, microscopic in that core of the ovary. But imagining it like a vault, because you can't tap into those teeny follicles, just like you can't tap into the ones inside the vault, is the same concept. But when the vault is more crowded, more eggs come out every month. And when the vault is less crowded, fewer eggs come out. And this is the concept of ovarian reserve. So when you go to your doctor and we do a blood test called AMH, or we do an antral follicle count, an ultrasound determination of how many follicles you have, that is what we're doing. We're looking at how many eggs are available in that month, how many are outside the vault. Now, IVF. In principle, what you are trying to do with IVF is get 1 month's group of eggs to grow. So instead of nature having only one egg grow and the rest of them dying, I'm going to say in IVF, I want all of the eggs available to grow. IVF success is dictated by how many eggs you get and the age you are. How many are genetic normal, right? So whether you test genetics or not, your age is determining egg quality. And egg quality is still also influenced by the world around you. We know that certain behaviors like inflammation, smoking cigarettes, marijuana, BPA exposure, those things hurt the quality of your eggs. However, age is still the number one determinant of success. No matter what, you cannot undo your age. And the way I think about your age is if you imagine all of those eggs inside the vault, they are held in a stage of cell division called metaphase of meiosis. But the important thing is that you have those chromosomes being held in a certain position from the moment you're born until you ovulate. I do not know why the body was made this way, but those eggs are in a stage of division. The chromosomes have met in the middle, and each chromosome is lined up in a very particular order. And the longer they sit there, the longer it is from your birth until ovulation, the increased chance that your proteins are going to break down and those chromosomes are going to change positions, therefore resulting in a genetically abnormal egg, resulting in a lower chance of pregnancy, higher chance of miscarriage, higher chance of random genetic abnormalities, what we call aneuploidy or numerical chromosome abnormalities. This show is brought to you by BetterHelp. As a fertility doctor, I ride the highs and the lows of each of my patients' experience. And I can tell you that is not something that we are meant to do alone. Therapy is all about deepening your self-awareness and understanding. And getting to know yourself can be a lifelong process, especially because we are meant to grow and change and evolve. And this is why therapy has been so beneficial for me. And if it's something you have not experienced, I highly recommend that you do. BetterHelp.com can connect you with a licensed therapist who can take you on that journey of self-discovery from wherever you are into knowing and understanding yourself better. If you're thinking about starting therapy, give BetterHelp a try. It's totally online, it is convenient, flexible, and suited to your schedule. All you have to do is fill out a brief questionnaire to get matched with a licensed therapist, and you can switch at any time for no charge if that therapist is not the right one for you. Discover your potential with BetterHelp. That's BetterHelp.com/AAW today to get 10% off your first month. Again, BetterHelp, HELP.com/AAW. You need to understand both the number of eggs you have and what percentage should be normal based on your age when you are evaluating doing IVF. Now, IVF again, I'm now trying to get one group of eggs to grow. Fantastic, right? If I get more eggs to grow, I have more opportunities to find the normal embryo or more opportunities to get you pregnant than I would normally have in a given month. All of that is good news. And IVF is used for a multitude of different reasons. Tubal disease, male factor, PCOS, endometriosis, age-related aneuploidy, recurrent pregnancy loss, fertility preservation, family planning, a slew of indications. But what is common is that IVF is never going to be 100% successful. If somebody is offering you a cheaper option for IVF, I want you to think strongly about it. Because This stuff costs a lot. I mean, the technology, y'all. We're taking eggs and fertilizing them and growing embryos and biopsying them and freezing them with the ability to thaw them and have it turn into a human child later. This is wild. And a lab takes a lot of money. The overhead is high. Embryologists, you need staffing. So how is one clinic able to offer it so cheaply? Typically because each individual person is going to do more cycles, therefore they're still making the money. And if they have to do more cycles, is it really worth being cheap? Is that really what you want, to have to go through it more times because of what they're doing is less successful? Okay, I'm going to circle back. So IVF, in vitro fertilization. In general, I'm now going to get 1 month's group of eggs that have been released outside the vault and get them all to grow. I'm going to take those eggs out of the body and fertilize them, and then I'm going to allow them to grow into embryos, plus minus doing genetic testing, plus minus doing an embryo transfer. When it comes to this process, no matter what, your body does not want to have all of the eggs available to it growing into mature eggs. Because if you have 16 eggs coming out of the vault every month, pretty average number for somebody who's 35, your body does not want to have 16 babies. It just does not. So it is going to resist allowing that to happen. In order to override this, you have to break up the brain and ovary communication. And that's what the IVF protocol is. Big red flags, warning signs. No clinic should just automatically give you the same protocol to everybody. If you hear the words, "This is the protocol we do here," that is like your doctor standing there waving a red flag. Nobody should say, "This is the one protocol we have." Every doctor, every clinic should have multiple protocols. And if there's only one, it is because they're either too busy to manipulate it, they don't have the staffing or the ability to do high level interpretation of what your body needs. And I don't think that's good. Now, it's okay for somebody to say, "Oh, in a situation like this, what I would typically do for someone like you, because you have endometriosis, because you have a high AMH, because of this is what I will do." That is a personalized protocol, and that is what I like. Now, again, the body doesn't want to do this. So most IVF protocols are a combination of suppressing the ovary and then stimulating it. When you think about suppression, the way I like to explain this is if you imagine the brain is now not sending out FSH. Suppression can be birth control pills because they're cheap, easy, and effective, medication called Lupron, estrogen, progesterone, testosterone, ovulation blockers, lots of options. But the take home is if the brain's not sending out FSH, I now have a group of follicles that have all come out of the vault and none of them are being stimulated. Therefore, they are all small and they are all hungry. FSH is their food. And if I follow that suppression with a stimulation, now I'm coming in with high doses of FSH. That's enough FSH now with injectable FSH, much higher than the brain would ever normally make. Now that FSH can go and fill up all the receptors on the follicles. Each follicle has FSH receptors on the outer perimeter. And now I can encourage all of those eggs to grow forward. And your doctor will pick the best protocol for you, and maybe it's awesome and maybe it doesn't work. I have a whole episode on canceled cycles that I highly recommend you listen to if you're considering IVF. But the take home is that the idea is that the more eggs I get, the better the outcome is going to be for you. And that typically requires medications to override the ovary. That is the protocol. Now, the protocol for somebody who has a lot of eggs and somebody who has a very low egg count are going to be different. Most people fall in the middle. So let's just say you fall in the middle, you do a typical protocol with Lupron and high-dose gonadotropins, you go through your 2 weeks of FSH, come in for your monitoring visits, have your eggs retrieved, and you get 16 eggs. We then go and fertilize them with sperm, and now you have 75 to 80% fertilized, which is pretty average. Let's say 12 have fertilized. Half of those make it out to the implantation stage embryo, which is a day 5 or 6 embryo called a blastocyst. And so now you have 6 embryos at that stage. The percentage normal will be dependent on your age. So if you're 35, 36, you'll probably have around 50% normal. So you have 3 out of 6. If you're 40, you're probably going to have 25% normal, 1 to 2 out of 6. If you're 42, 10 to 15% normal, 0 to 1 out of 6. So the number that comes back genetically normal, and when we talk about genetics in this context, we're solely talking about aneuploidy, the number of chromosomes that the embryo has. That is dependent on how old you are. The older you are, the less that number is going to be. You will get fewer embryos even if you get the same number of eggs. That is how the IVF math works. Now, when you talk about mini stim IVF, places will say this and they will say it is more natural, it will save you money, you will feel better. Now, the problem is, for most of the places, what they are doing is giving you one specific protocol that doesn't have suppression and then has low doses of gonadotropins, or even starts the cycle with medications like Clomid. Clomid causes the brain to release natural FSH, so you can get a little FSH boost from the brain. That level is always going to be lower than what we typically would give in injectable form. So what somebody's doing if they're giving you a mini stim protocol is often purposefully shortchanging you on the stimulation, getting fewer eggs than you could, in the idea of saving you money. If you're understimulating somebody, you don't have to see them as much, so you don't need as many ultrasounds or blood work because you're not going to over-respond, so I can see you less. And I am now okay with you not getting many eggs, because if you don't get pregnant, you're going to do another cycle and give me more money. I mean, not me personally, because I don't do it like this. People tack on to this mini stim protocol a lot of other things. And maybe they say, oh, well, we're not going to do ICSI because that costs money. Most modern labs don't charge extra for ICSI anymore. But some places will say, we're not going to do ICSI. ICSI is the type of fertilization where you put a sperm inside of an egg. And some people need this, especially if you've never had a pregnancy inside the body. You haven't proven that egg and sperm can meet together. Highly concerned if you're not doing ICSI. And these places sometimes are not doing genetic testing, and they're not doing any embryo freezing, or sometimes they're doing a fresh transfer. So most places with modern IVF, I view IVF, in vitro fertilization, stimulating as many eggs as I can, getting them out of your body, fertilizing them, growing them to a blastocyst, biopsying the placental component for genetic testing, freezing the embryo. Then you are going to have a frozen embryo transfer. Get the lining of the uterus ready, find an embryo that's genetically normal, grow the lining, transfer the embryo, ta-dum. So the IVF cycle and the embryo transfer cycle are separate for the vast majority of patients who do IVF in this country. And if you're doing genetic testing, that is part of this. Now, some places will say, you're not going to make many embryos, we shouldn't subject them to being frozen, blah, blah, blah. That makes me so nervous that they don't trust their lab, because it is so rare to have an embryo not survive the freeze thaw anymore. I quote patients, 1% of embryos don't survive the freeze thaw. It is well below that in clinical practice in a good lab. Doesn't mean it can't happen, but typically, if you have an embryologist skilled in doing a trophectoderm biopsy and freezing that embryo, it'll survive. And the data that you get from that, for most people, is worth it. But it's also quite a paternalistic thought to say, I'm going to decide you would rather me put an embryo inside your body, even if it's not going to become a baby. And maybe it's because I'm a woman, maybe it's because I've gone through loss myself. Heck no. A transfer is emotional, a pregnancy attempt is real, a miscarriage is devastating. And if there's a way to know that that embryo is not going to make it into a child, I would rather not have a transfer, not go through that miscarriage. I'd rather get to my next cycle if none of my embryos are viable, versus wasting time doing a transfer just for the sake of a transfer. So if you are 35 and now you go to a place that does mini stim IVF and you only get 6 embryos, and let's say 4 of them fertilize and 2 of them make it to a blastocyst and they just transfer them both. Well, the odds are that one of them would be normal, but we don't know that. And you might get pregnant and have a miscarriage. They might get pregnant with twins. You might not. And what we are finding, though, is that that person who just did the mini stim IVF got many fewer embryos than the person who did traditional IVF. They still went through shots. They still went through the most risky part of the whole endeavor, the egg retrieval. Yet they had 1 embryo to show for what they should have 3 if they'd done traditional IVF. Why does that matter? Because if you're not pregnant after that fresh transfer and you did mini stim, now you've got to go do more cycles, more egg retrievals, do the whole shebang all over. Or if you get pregnant and you want another baby in a couple years, you've got to do the whole thing again. And if you had done regular IVF, you would have had more embryos. You would have had another opportunity to just do a transfer if it hadn't worked, or to have a second child in a couple years. So when you do cost analysis of mini stim IVF, it is not more cost effective. This has been done. It has a lower chance of success. Therefore, it is not cost savings when it comes to having a child. So if you look at the outcome, getting to a child, not a benefit. So if somebody says get to a child cheaper with mini stim IVF at my practice, they are not telling you the truth, because people have looked at this in studies. Now, that doesn't mean that there's not a place for mini stim or for a different type of approach in somebody who's not going to have very many eggs. The patient who is only going to have 3 to 5 eggs, severe diminished ovarian reserve. I often don't need as strong of medications to get that person to grow. Right? There's only so many eggs. There's only so many FSH receptors. And so that person, for me, regardless of your age, is somebody who I tend to do a more minimal stimulation protocol, because I don't need all these hundreds and hundreds of gonadotropins. You only have 3 eggs. I just need enough to have 3 eggs grow. I still believe in the suppression stimulation idea. I still really want to synchronize those eggs. I do not love a natural cycle, just starting gonadotropins when you start your period for these people, because the body is so rooted in trying to have just one egg grow. I find you get a dominant follicle so much more frequently. But I have a minimal stim protocol. It uses birth control and an ovulation blocker. It uses Clomid and low-dose FSH. It's not the same as what I use for somebody who's going to get 12 eggs. That being said, I still believe in my lab. I still get the embryos in the lab and ICSI them and grow them out. And if you're 35 or older, we talk about genetic testing with your embryos. Or if you want multiple children, we talk about genetic testing. So you might save $1 on the stimulation meds, but you're still doing regular IVF. You're still going through the egg retrieval, still having all the fancy lab stuff done. I'm not shortchanging your egg's chance of making it because of what I'm doing in the lab also. And I think that's an important distinction. Other people who might get a more minimal stim approach are your extremely high responders. So both ends of the spectrum. The PCOS patient who has an AMH of 18. I do not need all 80 eggs to grow. That's the highest number I've ever gotten with egg retrieval, is 82 eggs from a PCOS patient. She had undergone IVF in another country and had terrible OHSS, ovarian hyperstimulation syndrome. And then she came and we did IVF, and we did a more minimal approach. So we did lower dose gonadotropins. We did lead in with some letrozole. We did a Lupron trigger, but all the stuff still happened in the lab. We weren't shortchanging her experience, but in her, we did purposefully understimulate her because I didn't need 100 eggs. So there are certain times where the protocol should be personalized to the patient, and it might be a minimal stim protocol, but it doesn't need to be advertised as a minimal stim or a mini stim cycle or a natural IVF. Natural IVF is when I don't even give you medications. I'm just following and trying to get the 1 egg you're ovulating. That I do not understand. Truly, the cost of what needs to happen in the lab is worth trying to get 2 eggs or 3 eggs. And in our very, very low responders, that's what we're still shooting for, not just accepting the 1 that you might be ovulating naturally. The other time where we do a minimal stim protocol is when we're doing an entire minimal stim cycle. And this is acknowledging purposeful understimulation. This is InvoCell, a cost savings technique, and it is only for very specific patients, typically younger patients with PCOS or tubal factor, not for unexplained, not for male factor, in my opinion. I am purposefully understimulating you, Clomid low-dose FSH, trying to get 8 to 10 eggs because that's what the device holds. InvoCell is a device, a little plastic chamber that eggs and sperm both go in, and they allow a vaginal incubation. By nature of InvoCell, still stimulating the ovaries, still coming for monitoring, still undergoing egg retrieval. But now I'm putting your eggs and sperm in this plastic device, not in my IVF lab. And I'm putting this device in your vagina, holding it in place with a diaphragm. And those embryos are incubating in your vagina for the next 5 days. Now, I'm relying on egg and sperm to be able to get the job done. So your sperm's got to be able to swim into the egg and fertilize and grow out an embryo. And then 5 days later, I'm taking it out. Hopefully, I have an embryo that I can transfer. If I have any extra, I'm freezing them. And these are not being genetically tested. This is a fresh embryo transfer, not a frozen. It does save you money. It also results in lower embryos for the vast majority of people than they otherwise would have. But in some circumstances, the ones I said previously, and another good one is donor sperm. If you are in a relationship where you're going to use a sperm donor to conceive, success rates with InvoCell are higher than IUI, and you might not need full-on IVF depending on your situation. So InvoCell does save money, purposeful under stimulation, not doing ICSI, not doing genetic testing. Most people, when we break down the math, do not end up choosing InvoCell because their ultimate goals and the ultimate desire to have a family, their potential is better served. The ROI on a cycle of traditional IVF with ICSI, genetic testing, freezing an embryo is higher for them for their personal reason than InvoCell makes sense. So what I hope you see here is that a minimal stimulation protocol should mean using lower doses of medication to get the eggs to grow. You should understand what your potential is. And if you are choosing a mini stim protocol, are you selling yourself short? And are you now having a lower chance of success? That's what every study shows. So yeah, it looks really good to spend $8,000 on IVF instead of $16,000. But if you got to do it 3 times, did it help you? Took you longer. You went through more egg retrievals because it had a lower chance of success each time. Ultimately, personal choice, right? I believe that medicine should be a place where your team is describing your options. I will have some patients say, I want to do a mini stim protocol, and I will say no, right? Like, no, based on your math and this is the protocol you need, and here's the reasons why. I'm not willing to allow you to do something that's going to result in a lower chance of success. And most people don't want that. Most people actually want the highest chance of success possible, but they've seen these marketing campaigns, or you'll feel better, or it's better for you. And the one that I hate the most is this one telling you that, well, your egg quality will be better with a mini stim protocol, that it's better for your eggs, or for some reason they'll be more genetically normal. That's absolutely false. The genetics of the eggs, what? That's predetermined. I mean, that's nothing to do with if you do a mini protocol or not. And the opposite is that some patients who have a lot of chronic inflammation actually do really great with a Lupron protocol, which by nature is not a mini stim protocol. Because if I'm giving you Lupron and totally shutting down the brain, I've got to come in with all the gonadotropins possible to get the ovaries to respond. So the idea or the marketing that mini stim is better for you or has better outcomes is false. Is it cheaper? Typically. Is there a reason why things tend to be cheaper? Typically, yes. All right, well, I hope that answered some basic questions about IVF and what a mini stim protocol is. Again, it's not that I'm universally opposed to them. I have patients doing a mini protocol right now. I just never call it that. It's just the protocol that's right for you. And I'm not shortchanging anything in your lab experience just for cost savings if it's not what's best for you. All right, well, now it is time for Fertility's Sake, FFS. This is our weekly Q&A where you submit questions that I answer. These questions you can submit on Instagram at nataliecrawfordmd every Monday. And these questions will be answered here on the weekly podcast, in the newsletter, nataliecrawfordmd.com/newsletter, and on Instagram. So these are questions asked by you. All right, I am diagnosed with DOR, which is diminished ovarian reserve. My estrogen levels are low. How can I increase my estrogen? Now we have to understand how the ovaries work. And again, DOR means not having very many eggs. What happens is the brain then has to send out a higher level of FSH to get the ovary to respond. And the ovary starts growing an egg. And when it grows an egg, it makes estrogen. So depending on when it is checking, you sometimes can have a lower estrogen level because you are not responding to the FSH quite as appropriately. However, giving estrogen is not the answer here. The no estrogen is from the improper ovulation. So for the most part, this is fertility treatments, something that makes you ovulate better, growing a better egg. Secondarily, estrogen levels can also be low if you have low body weight. So if you have DOR, but you're also very thin, or you're dieting, or you exercise a lot, trying to make sure you're not in a calorie deficit, trying to make sure you're eating lots of nourishing foods, not over exercising, getting good sleep, those things do also impact the cycle from the brain to the ovaries. What is your opinion on taking metformin for insulin resistance? I love it. I put all patients with documented insulin resistance on metformin. Metformin is a medication that improves your sensitivity to insulin, meaning you're able to utilize the sugars that you eat, carbohydrates, other fruits, have natural sugars, but utilize the sugar in all of your food in a more efficient way. Metformin also has the added benefit of changing some of the ovarian androgen production, which can be especially beneficial in people with PCOS. Metformin can help some people lose some of the insulin resistance weight, which tends to be on your abdomen, and it can overall make your hormones function better, for lack of a better word. The reasons I don't like metformin is that it can be hard to tolerate. You can have some bad GI side effects, especially as the body is first getting used to it. This can be diarrhea and bloating and gas for the most part, sometimes nausea. However, I recommend titrating it up. That usually combats it. And I find that those side effects are worse if you're still eating a poor diet. So if you combine an improved dietary pattern with the medication, most people do tolerate that fine. Is it normal for your AMH to go from 20 to 9 in a year? Overall, let's remember that AMH, as I said earlier in this episode, is made from the cells that surround each of the follicles. More follicles outside the vault, higher AMH. Both of these values are extremely high no matter your age. Both of these values are consistent with PCOS, meaning even though AMH is not in the diagnostic criteria, having a certain number of follicles is, and with AMH values this high, that is most likely a contributing factor to your medical care. Normal AMH, even if you're very young, is typically not going to be higher than about 4.5. So both the numbers 9 and the number 20 are very high. This means there's a lot of follicles. One thing we do see is that sometimes with PCOS, you see improvement in AMH value as you have decrease of inflammation or improvement in lifestyle factors. However, these could also be two ends of the extreme because month to month, you are going to see a variation in your AMH. And even though we say usually that's about 30%, you can imagine the truth may be somewhere in the middle. People do run out of eggs, even people with PCOS. So do I think that somebody really went from 20 to 9 and it's in a linear drop? Probably not as it seems. I understand. You get a value like this and you might say, oh my gosh, it went from 20 to 9 in 1 year and now I'm going to be at 0 a year from now. And that's not really the case. For the most part, egg count every month does usually fluctuate around the norm. Those is probably just two extremes, although it does usually decrease over time. It's rare to see a drop this dramatic unless you had an ovary removed, a cyst removed, endometriosis, chemotherapy, something profound. Can endometriomas go away or shrink? Also, can they be diagnosed by ultrasound? An endometrioma is an endometriosis cyst in the ovary. If we remember what happens in ovulation, a follicle grows, that follicle ruptures, allowing the egg to be released. That follicle then reforms and makes the corpus luteum, which makes progesterone. An endometrioma is when endometriosis sneaks into that follicle after it ruptures, and then you have this persistent ovarian cyst, which is the endometrioma. Endometriomas do not go away. They might change in size slightly based on who is measuring it, but ultimately, once endometriosis has invaded inside the ovary, it's not going to leave. And if you go and surgically remove it, that's the only way to get rid of it. You typically are going to also remove other healthy follicles and see a decrease in your ovarian reserve. Most of us do not remove endometriomas if you're trying to get pregnant because we want to have as many eggs as possible if you need IVF. If, however, they get very big, you have ovarian torsion, cause a lot of pain, those are secondary situations, and medical care has to be personalized, but you can see an endometrioma on ultrasound. Last thing is that an endometrioma is what we call a homogeneous cyst. It's filled with blood. It does look very similar to a corpus luteum. So occasionally you see a cyst on an ultrasound. If it's in the luteal phase of the cycle, you might tell a patient this could be a corpus luteum. this could be an endometrioma. A corpus luteum will go away and endometrioma will not. So repeating an ultrasound to see if it's shrinking or changing can help you differentiate between these two situations. All right, well, I hope you enjoyed hearing some of those answers to the questions. Again, you can ask these questions every week on Instagram on Mondays at nataliecrawfordmd. You can also follow along on Instagram to get answers there, and you can subscribe to the newsletter, nataliecrawfordmd.com/newsletter. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.
If you're looking for another surprising investigation into the criminal justice system, check out Bear Brook from New Hampshire Public Radio, hosted by me, Jason Moon. Bear Brook is back with a new season and a new case. Jason Carroll is serving life in prison for a murder he says he didn't commit. More than 30 years later, is it still possible to get to the truth? And who gets to tell it? Listen to Season 2 of Bear Brook wherever you get your podcasts.